Hey everybody, my name is Cara, and I am the host here for BFR Tuesday. I've been hosting this for about almost 2 years now. Oh, it's been over 2 years. Every Tuesday, we talk about stuff relating to blood flow restriction training. Today, I think I'm going to talk about hypoxia and some things that I've been learning around creating hypoxia in the body, systemic hypoxia, not isolated hypoxia, and how that might apply to BFR training. So first thing I'll do is just see if anybody has any questions for me before I get started. So just say hello in the chat tab. Hey Jen, how's it going? Yeah, let me know if there's any questions to get started, and then if not, I will. I'll get going with what I wanted to talk about. Hi Kaylee, thanks. Oh, no problem, my pleasure. Yep, every Tuesday. Let anybody you want to know, and then I just put the replays on my YouTube channel, and I'll start working on getting it on my website, which probably is where it should be. Thanks, Kevin. Thanks for saying hi. Okay, so okay, and a general question. Okay, what do you got, Jen? Let's answer that general question. Yes, sir. Thank you, Lawrence. Thanks for coming. Jen, do you have a question, or you might be typing it right now? I'm going to give you a sec. When performing BFR, you mentioned in the notes that the best way to generate systemic effects is via use of the lower extremity. Yeah, so especially if we're looking at aerobic adaptation. So this is the way that I think about it. I put the cuff on my upper limb. The amount of blood flow that's restricted here is going to be very, very minimal compared to I have the cuff here and everything down here. So what we're going to probably end up, what we kind of know is that the hypoxic environment is creating some sort of change within that local area. Then within that local area, there's got to be some sort of information going to the brain, which then creates the systemic response. So if there's a larger area of hypoxia, in my mind, that would equate to larger systemic effects. And that's what I see as well. I think in the clinic, I see when we use the upper extremity, yeah, very valuable, and you're trying to get strength and hypertrophy, but where we see the biggest change is when we use it in the lower extremity, like walking. You're going to see much better change aerobic capacity wise if you use it in the lower extremity compared to if you do it in the upper extremity. Plus, the stress is just so much less in the lower extremity. So people can go for a walk. They can get strength of the lower extremity measured via torque. You can get hypertrophy of the lower extremity, and you can get aerobic capacity change. And remember, the adaptation effect occurs because of cardiac output change. So if I have cuffs around the lower limb, that means I'm going to reduce the amount of stroke volume considerably compared to the upper extremity. If I decrease stroke volume, my heart rate has to go up in order to match the amount of cardiac output that I was doing prior to cuff inflation. So I think the stress level is much higher. And it's kind of like, when we're looking at central nervous system fatigue versus with normal exercise, if I do something multi-joint to the lower extremity, it's going to be much higher stress to the system compared to doing upper body. So let's say an air squat compared to like a push-up, I think is going to be much different. It's just harder. It's just more intense. So I think that's my rationale. I don't have any research to back that up. It's all anecdotal and just in my thought process about what's happening. if some of the stuff that you reviewed was a year ago, I would definitely go over the BFR 101 course that I did. Let me see if I can find a link to that, because I did a BFR 101 webinar 3 weeks ago. And it's kind of my latest thoughts around BFR. Let me see if I can find that. I'm going to do that with a new window over here, and then I'll link it. And let's see if I can find that guy. BFR 101. Okay, here's the handout that goes with it, and I'm going to find the video. I'm looking. BFR 101. Oh, there we go. This is about 2 hours. I sent this to my buddy the other day, and he was just like, dude, it's 2 hours. I'm like, I know. There's a lot of information when it comes to doing this BFR stuff and trying to do it appropriately. So I think, Jen, I don't think much has changed from last year. I think that if you take this, there's not going to be a ton of differences, in my opinion, probably, but I haven't compared. So let me see. So if, for example, someone has a wrist sprain, you can't lift their usual weight load, better to use the cuffs on the upper extremity for the localized effect, or on the lower extremity for the broader systemic effect. Well, I would do both, probably. I would do lower body for the systemic effect. Then if they could do some lifting with that one limb, the injured limb, you could put the cuffs on and just do some isometrics. Or if they can't at all, like it's like a really bad sprain, then put it on the opposite limb and then get the crossover effect. Remember, we get three primary effects from BFR. We get the localized effect, which means it's distal to the cuff. We get proximal to the cuff, and then we get crossover as well. And so depending on how much time you have with somebody, I would probably try to stress the specific tissue, but I would also look at crossover and then systemic. So you have what would a full hour with me look like? I'd probably start them on some sort of aerobic capacity, doing some sort of walking or cycling. That would be 20 minutes. Then they would do, I would probably then do my manual therapy if I was going to do manual therapy with them. So that might be 15, 20 minutes. And then I would finish with probably some supportive taping or kinesiology taping, and then finishing with probably 1 or 2 exercises of, if it was really bad, an isometric, very light load, 1 minute on, 30-second rest, 1 minute on, 30-second rest, 1 minute on, and then deflate, probably 2 exercises, 1 for the extensors, 1 for the flexors. Then that's probably about it. If they weren't able to tolerate an isometric, then I would do crossover and I would do the opposite side, or they could do maybe some grasping. Worst case scenario, maybe you could do something proximal to the cuff, scapular stabilization. You could do something as an isometric for the elbow. I think most times I can find something to do. So hopefully that answers that BFR 101 should help answer any of those. And then also, I should also be able to give you, then the next thing that I did was a first 30 days with BFR. That was, and you can find that on the Smart Tools website. under online, I think it's online library or in online education. And that one had my, like if I'm starting off with BFR, never done it before, what are my first 30 days? So you kind of have this on-ramp program of 2 weeks, using lighter pressures more. You're using lighter loads, less exercises, more isolated exercises, then you're gradually building up. So hopefully that helps. Any other questions before we get kind of going with one new message? Okay, yeah, no problem, my pleasure. Okay, so today what we're going to talk about is measuring yourself or your client or your patient, their ability to handle breathlessness. And what we call this is, it's called your BOLT score, B-O-L-T. So it's your B-O-L-T. And what you need to do this is you need your phone set on timer, and because you're going to want to set the timer. And so I'm going to do that on my phone. I'm going to set it on stopwatch. So I just have it on stopwatch. What we're doing is we're testing to see how somebody is able to tolerate the lack of oxygenation. So we're going to hold our breath. And we're going to count how many seconds it takes until you really feel like you need to take a breath. And where this might be valuable is on an initial evaluation. Anybody less than 25 seconds is pretty sensitive to builds in carbon dioxide. So many people think that the reason that we end up having to take a breath when we're underwater or we're holding our breath is the lack of oxygen, but it's actually the buildup of carbon dioxide sends a signal to our brain that carbon dioxide is building and we want to take a breath. So the way that we measure this is you're going to take a breath in through your nose, normal breath out of your nose, hold, and I'm going to hold this until I feel either kind of contraction through my throat, or I feel like in my diaphragm that I need to take a breath. When I end up taking the breath, I shouldn't feel like I need to take this huge breath. And if you follow me for a while, you know that I'm a big component of only breathing through your nose unless you are exercising at above 85% of your VO2 max for lots of reasons that I'll talk about in maybe some other webinar. But primarily we're looking at, filtering air. We're looking at using the oxygen that we have there much better and more efficiently, getting it to deeper areas of the lung and humidifying the air and warming the air. So when we breathe through our mouth, we're not getting those benefits. When we breathe through our nose, which is the way that it's designed, it allows us. So for many of my athletes, I use tape, kind of looks like this, and I have them tape their mouth while they're exercising or during the day in order to get them used to breathing through their nose. Now, up to 65% of people have abnormal septum, or they have a deviated septum, so they don't feel like they're getting enough oxygen. So it takes a little bit of training. So for example, I had a patient come in last week who chronic headaches, like chronic migraines, but she got them kind of in the middle of the night. And so two things kind of click my brain when somebody's starting to get symptoms in the middle of the night, especially in their neck. Well, three things really. One is lack of oxygenation. And so how are they breathing? Are they breathing on their back? Are they laying on their back? Or are they on their side? If they're on their back, they might be occluding the airway, and so they're having to get more oxygen. So a question I will ask them is, do you wake up in the middle of the night and you feel like you need to drink water because your mouth is so dry? Number two, do they snore? And do they snore through their nose, or do they snore through their mouth? Sometimes we have to ask their spouse or significant other if that's the case. Other things that can occur is if they ate early or they didn't eat a lot of dinner, then they might be dumping in the middle of the night and so they're dumping and they're getting, lack of sugar, or they just have a crappy pillow. That's also a possibility as well, not giving them enough support. So some things were running through my mind with her, that she was getting these headaches in the middle of the night, and then she was also getting aura and then headache in the afternoon. So I thought a couple things. Number one was posture, strength of the neck, which we tested. It was very, very weak. She had already been supplementing with magnesium, which is another supplement that I'll use. We usually do it by intramuscular injection, which will usually take care of if there's a deficiency, which most people are. Takes care of these things really quickly. But what I found with her is her Bolt score was only about 8 seconds, so very, very low. So she's not using the oxygen. She ends up being a mouth breather. So we're going to do this Bolt test. Well, long story short, I gave her some breathing exercises. I gave her some mouth taping techniques for night to get her used to breathing in through her nose at night. And I gave her some strengthening for her neck, and her symptoms have improved dramatically within just a few days. So I'm very hopeful that this is going to be a solution for her. So Bolt score. So how we're going to do this: small breath in, and I'm going to do like we do when we scuba dive. Breathe in, breathe out, hold. Okay. So we're going to take small breath in, small breath out, and hold and hit your timer. Then I started to feel like I needed to breathe. So that was 35 seconds for me. This has been getting better as I've been working on it. So let me know. Let's see. So I had 35 seconds. Let's see what everybody else got, if anybody else is playing along. 14. Okay, so it's okay. You just got to work on it. The best time to take your Bolt score is in the morning when you first wake up. 30, Jen. Nice. That's really good. Anybody else out there? And there's a whole different progression of exercises that you can do. Oh, I forgot to say good job. Moderate discomfort. Okay, so you may want to stop it a little bit. So Bolt stands for blood or body oxygen test. And what it really is testing is your sensitivity to carbon dioxide. And why do I bring this up during a BFR course? What I find consistently is that when we start using the cuffs, people say that their time to fatigue gets much longer. So that means that they're resisting fatigue much longer. And what that tells me is that, number one, you're probably able to buffer exercise acidosis better, meaning you're less sensitive to the exercise acidosis, the hydrogen ion accumulation. Lactate is doing a better job of buffering not only outside the cell, but inside of the cell in order to not allow that acidosis to increase. So they're doing a better job of doing that. Doing this type of breath holding and breath testing should improve as you do more and more BFR, because your body is getting used to this anaerobic environment. Number two is that as carbon dioxide increases, there's something called a Bohr effect. And so as carbon dioxide increases, our body's ability to cleave hemoglobin and the oxygen on the hemoglobin in that working muscle gets better. And so two things really help this. Number one, carbon dioxide elevation which is basically an accumulation of aerobic metabolism. If you go back to the Krebs cycle, one of the byproducts of the Krebs cycle is carbon dioxide. And so we always think of these metabolites as something that's bad. Like, you know, how long have people said that lactate or lactic acid is bad? But I don't think that's the case. I think lactate, not lactic acid. I don't think that the human body makes lactic acid. Lactate accumulates, that acts as a buffer. It also, in most circumstances, then goes to the liver, hangs out in the liver, turns more sugar into something that's usable, and then goes back to the working muscle. So lactate is a good thing. I lost earbuds. Okay. So to try to connect the dots here is that if we can train people to work better under hypoxic environments, either with BFR or systemically with breath holding techniques, then we should have a longer time to fatigue. We should be better able to tolerate exercise acidosis. And so I think that there's a lot of really solid benefits here. And I think part of the initial evaluation with somebody that I'm going to do BFR with would be this blood oxygen level test. And so what I'll do is do a better description and a written out description on how you can do this. And then I'm also going to start covering a little bit more about how to start exercising people that have low Bolt scores, specifically less than 25. Any questions about Bolt score, why I think it's important as it relates to BFR? And I'm not getting into how to improve it or anything right now, but the one thing that you could do is just encourage yourself or your clients to breathe in through their nose as much as possible. All right, no questions. Awesome. Well, I'm already past my time. It's been about 25 minutes. I try to keep these to about 15, 20 minutes. I appreciate you coming on. If there's any topics that you are interested in regarding BFR or anything else, just let me know, and then that way I can cover them. This replay will be put on my YouTube channel, and I'll also put a description of the blood oxygen level test or body oxygen level test. Check out my BFR 101 course. It's about 2 hours, plus it has a handout really kind of summarizing where I'm at right now with BFR. And thanks so much. Have a great day. Stay healthy and safe.